Hello friends, today we are going to discuss about Q waves. A Q wave is any negative deflection that precedes an R wave. Negative deflection occurring before R wave is P wave. What it represents is the normal left to right depolarization of the interventricular septum. See, this is your SA node, and this is your AV node, and this is your bundle office, and this is left bundle branch, right bundle branch, and these are your Purkinje fibers. Normally what happens, SA node generates the electrical activity, that's why it's called as pacemaker, and it reaches the AV node. The depolarization wave reaches the AV node via internodal fibers. After a delay, it passes through the bundle office and then bundle branches. So this interventricular septum is depolarized by the fibers which are arising from the left bundle branch from left to right like this. So left bundle branch gives septal fibers. So the direction of depolarization is from left to right. So one thing that I want you to remember is whenever the depolarization vector goes away from the leads, it is perceived as a negative deflection, and the depolarization wave goes towards the lead, it is perceived as positive deflection. So these depolarization wave from left to right is going away from the leads V6, V5, 1 and AVL. So in these lead 1, AVL, V5, V6, this negative deflection, this depolarization, septal depolarization is represented as negative deflection, that is called as Q waves. So a small septal Q waves are typically seen in the lateral leads 1, AVL and V5, V6, that which is normal. And one more basic thing that I want you to remember is more the muscle mass, more the voltage. Let's suppose septum is hypertrophied like this. So more voltage, so more bigger Q waves you see. So that is the finding in hypertrophic cardiomyopathy. So when do you call a Q wave pathological? So pathological Q waves has four criteria. When the Q wave is more than 40 milliseconds, that is 1 mm wide, or when it is more than 2 mm deep, or when it is more than 25% of the depth of the QRS complexes, or when Q waves are seen in lead 1, 2, 3, it is abnormal, it is pathological. So where do you see pathological Q waves? One is myocardial infarction, as I said previously, cardiomyopathy, hypertrophic cardiomyopathy, infiltrative cardiomyopathy, and lead placement errors. When upper limb leads placed on lower limbs, you get this Q waves. So absence of normal Q wave is also pathological. So absence of normal Q waves you see in left bundle branch block. Let us look at few examples of Q waves. So this given ECG shows lead 1, okay, lead 2, okay. There is ST elevation in the lead 2, 3 and AVF. So inferior ST elevation is there, and inferior lead you are getting Q waves. You are getting Q waves in the inferior leads. So this is Q inferior MI with Q waves, that is acute inferior wall MI. The diagnosis here is acute inferior wall MI. And the next ECG shows Q waves in 2, 3 AVF and ST inversion. So this is also inferior waves with T wave inversion. It is due to previous MI, previous inferior wall MI. And let's suppose in this example the ECG shows ST elevation in 1, 2 is okay, AVL, okay. Lateral leads shows ST elevation, and the lateral lead shows Q waves. So this is feature of an acute lateral MI. And the next ECG shows Q waves in 2, 3, V5, V6. So there are almost more than 5 mm depth. So this is a patient of hypertrophic cardiomyopathy. One is pathological Q wave, I have deep Q waves. Another one is there is RVH, right ventricular hypertrophy. So this is a case of hypertrophic cardiomyopathy. So that's it for this video. Hope you like this video. Thank you.